Okay, we're back from that short intermission, and as you know, we were talking about chronic obstructive pulmonary disease. And before the break, I was describing a little bit about what that normal bronchiolar epithelium look like. So let's go to the slide if we can bring that up, because I have a nice slide to depict that. And what you'll see up there is on the upper left-hand corner, those cilia, those hair-like substances, and you can actually see an electron micrograph if you go down to the left, and that shows how those little fine hair cells are up there. And then if you look over to the right, that's a histology slide, which means that's a section of the slide that has been stained. And what you will see in that is, if you look on that, on the far right slide, you'll see that looks like I don't know, maybe kind of, looks like hair. I mean, a fine hair. It's like someone that was balding. Well, that's basically that columnar epithelium, or the cells that are lined up below it, and in the middle of that you might see what they call a goblet cell, and that goblet cell produces the mucus, which basically lies on top of that. And this is what I'm talking about. Epithelium meaning skin, and basement membrane, really don't need to worry about that. Those are just histologic terms that describe different layers in the tissue. This slide really depicts what I was trying to describe to you. Again, same basic principle, and you can see that below that there's going to be that green bar, which is the mucus that coats our lung, and everybody knows mucus is green, but it's really clear it's only green in mucoid conditions. And that brings up another good topic, which is that a lot of people get colds and flus, and they think that with they producing a green mucus that they're infected, but that's absolutely not true. Infections in the bronchial mucosa are actually yellow mucus. Yellow is a sign of infection, and not green. That's basically just a lot of dead white blood cells that are basically swallowing up whatever it is that they do, and that produces a green mucus. Yellow has a lot of pus, which is bacteria. So just so you're out there and you know that, if you're green or brown, it's normal. If you're yellow, it is abnormal. But anyway, those hair cells are in that mucus, and they're moving that mucus up, over, and out of our lungs. So we talked about air, the sick airway, mucus plugging and air trapping. You can see that basically what I tried to diagram there is that the arrow shows the air going over this mucus plug as you expand or open up your lungs, and then as you collapse your lung, meaning the lower slide will show that the air is being trapped behind that. So that causes this gradual expansion of our lungs and the gradual blowing up of the small alveoli or balloon cells in our lung tissue. This is kind of a little bit of a more morbid picture, but it shows basically the smoker's lung, which shows those burned out big holes in that lung, which are those black spots. And then you look at the normal healthy lung, which looks like a sponge, and basically has a lot of surface area for oxygen and air exchange. And then you have these dark circles, which were basically blown up areas of your lung, which are called blebs. There's a lot of tar down in that lung. There's a lot of nicotine. There's a lot of problems with that. Can't really clear all that stuff out. So I guess the next question would be, do you have any questions about why you should quit smoking? Look at the two differences of the lungs. If you can't figure that out, I know smoking is a very tough addiction. We've gone over that in this show. And basically what we do to try and tell you whether or not you have COPDs, we actually have you breathe into a spirometer, basically a device that measures your lung, how much air you can get out of your lung. And this is the type of curve that we get when you actually breathe air out. And what they have, there's a device that you basically would be like blowing up a balloon as hard and fast as you can. And I don't know whether it comes up very well on your screen, but you can see the blue line is the actual air being moved out of your lung. And what that first little letter says is called FEV1, okay? And this is a volume over time, meaning seconds being on the bottom part, and then the volume, the amount of liters that you get out of your lung being on that top left, or what we call the y-axis. And so we're measuring how much air you actually breathe out of your lung over time. And what we should be able to do is get at least 80+% of our air out in the first second. And that's called FEV1, or the forced expiratory volume in the first second of breathing. And you can imagine that if it's obstructed, meaning there's something in the way of that, then you're not going to get that 80% of air out of your lung. And the top number is called your forced vital capacity. That is how much air is totally in your lungs. How many liters can you fill up in that balloon? Now that is different for everybody, and there are what we call a percentage of normality, meaning based on your age, your height, and your weight, we have what's called a normal amount of forced vital capacity. We're going to be liters. If you're a small person, maybe it's 2. If you're a big man, it could be as much as 4. But it doesn't matter what your total air is, it just matters how well you get that air out of your lungs. That's called the forced vital capacity. And then we have the FEV1, which is how much air you get out in the first second of breathing. So those are the measurements that we look at, and that's how we help to determine whether or not. Now, if your forced vital capacity is reduced and you get the normal amount of air out of your lung, that's called a restrictive lung disease. So as the name sounds, your lungs are restricted in the volume of air that you can breathe in. Conditions that can cause that are pulmonary fibrosis. That's a very bad condition, but you actually have a hardening of your lung tissue and a very, it's just like the lung doesn't want to move. A lot of those are genetic based, but there are certain drugs and certain conditions that can cause that. If you had a really bad arthritis and a lot of broken ribs and things of that nature, and you couldn't really expand your lungs, then that might create a restrictive lung disease. So there are a lot of people that I see today that have both a restrictive and an obstructive lung component, which means their basically lungs can't really expand more than 50% of what they normally should do, and then they can't really exhale more than 50% of that limited quantity of air that they can take in the first second. So from basic math, 1/2 times 1/2 equals 1/4. So these people are operating on a 25% of their lung capacity. And trust me, these people are short of breath, they're having a lot of difficulties, they're usually needing oxygen, and they're not doing very well. They have chronic infections, they have all types of major issues. And so that's how we look at that particular thing. So we have another slide I want to bring up, and this is basically just shows those issues that I was talking about, the normal spirometry and the different types of curves that you can see. And that first curve is basically looks at volume over time, and you can see that it's an obstructive component. You can see how long it takes to get all of that air out of the lung. That would be the bottom curve. The top curve would be the normal one. Now, the restrictive lung disease that I told you about, you can see that the top curve being what that person would be with a normal lung, and then you can see that, well, they get that air, they start out just like they're supposed to, but all of a sudden they peter out. They don't really get much of a volume. And this mixed component, again, is what I described as 25%. You see a nice flat curve, which means they're just really having a hard time getting that air out of the lung, and then all of a sudden it kind of plateaus at a much reduced volume. And those people have a lot of problems over the long term. The thing you should know about chronic obstructive pulmonary disease is that it is a progressive disease, which means it progresses because you lack the mucus clearing mechanisms of your lung. And this is why it's so important for, as we talk about treatment of chronic obstructive pulmonary disease, some of the issues that are out there that help to reduce your mucus production help to reduce air trapping. And then also some of the things we do to open up your lungs help to get rid of that. So, you know, we'll talk about that. We're going to be going to break here in a few minutes, and then we'll talk a little bit about some of the treatment and maybe a little bit about some of the statistics about COPD. But your whole objective is to try and let that air out of your lungs so that you can further reduce the amount of destruction that takes place from those alveoli not being blown up so much. So again, what I talked about was if you can reduce smoking, you can actually, your tissues will actually come back to normal, which means you will actually start to produce those columnar epithelium again, and you won't get the mucus cells are always there, they don't change, but now you'll be able to move that mucus up out of your lung. And so that's why we talk about lungs going back to their normal functioning, basically getting the mucus out, clearing it out. And if you notice people that have a smoker's cough, why do they have a smoker's cough? Because they lack or destroy their natural mucus clearing mechanisms in their lung. And so they have to cough that mucus up. They can't breathe it up. They can't swallow it. They have to cough it up. And so they'll do that all day and all night, and it's a horrible situation. Anyway, we're going to go to break, and when we come back, we'll talk a little bit about more COPD. Thank you for tuning in tonight. Hi, I'm Dr. Michael Reiner, your host of the Independent Doctors of Pahrump, a TV show that airs Monday night on Channel 46. I want to remind you that I am a practicing physician in Pahrump, and I'm an independent practitioner, which means I am not bought by any insurance company or corporate medicine. We provide the highest level of care. We have nurse practitioners. We have other physicians, specialists who come to our office. Please come visit me. I'm at 1316 East Calvada here in the heart of Pahrump. Thank you.